iTech India welcomes all the participants for today's National Distance Learning Seminar Series. Today's topic is learnings from differentiated service delivery models, and the speaker is Dr. Ramesh Reddy Allam. Dr. Ramesh Reddy Allam is the public health specialist with Centers for Disease Control and Prevention, that is CDC. We welcome you, sir, for today's session and request you to start the session.
Thank you all. Thank you, Shweta. So today's discussion mostly will be around the differentiated service delivery models that some of the states have undertaken. And prior to going to what are those differentiated care models, I'll just go through our operational guidelines to make you all understand who are those patients we should really be looking at differentiated care, and what is provided in the guidelines, that guidance of who should be referred and where we could implement such models is what I will be touching in the first half of the presentation. And then we can see types of differentiated care models, and then I'll also share some examples of some models that we currently have within the program context. So the definition of a differentiated service delivery is, this is basically an approach that simplifies the services for better serve the needs of the PLHIV and optimize the available resources. So this is directly taken from the WHO 2021 service guidelines that you see on the right side of your screen. And this approach is not just applicable to either treatment services or prevention or anything, but any health program or any health initiative, we could actually take it up and put it up as a differentiated service delivery model. And why this differentiated service delivery model is that not that every patient requires the same type of care. For example, if you have 100 patients in the OPD, you will not be requiring to give all the 100 the same care. Some may require 10 minutes of your time, some may require just 5 minutes of your time. So this is what we need to differentiate our care, and we have to move away from that one size fits all model. And this DSD will tailor these HIV services to diverse groups of patients living with HIV. That means not just a general population will be coming to ART center. So you see some key population groups, some adolescents, children, prison inmates. So there are several different types of patients with different risk stratification who come there. So every person being offered the same care shouldn't be followed if we really have to ensure that the patient is retained on antiretroviral therapy. So this infographic that you see is the building blocks of the differentiated service delivery for HIV treatment specifically. This is, and what you see here is whenever we start defining or trying to put up a plan for a differentiated care specifically for treatment, we need to understand what is that we are going to do. So is it like you want to monitor the patient, you want to help the patient on adherence support or laboratory tests, and who should be doing such type of care? Is it the medical officer, nurse, pharmacist? So who will be doing that is another critical thing. Then when should the patient come? Should the patient come every month, or should we offer that service every 6 months? And where it should be? Should it be in a TI setting? Should it be in a community setting? Should it be somebody going visiting the patient's house? So this is how broadly we need any one type of care we need to take and try to answer these questions before we establish any differentiated care model. And this again, if we have to go into a different sort of picture, like the same thing what I told you, what stands, for example, what is that service we are looking at? Is it ART initiation and refill? Is it adherence support? And when do you want to give? Or who is that health cadre who is involved in it? And where do you want to give? So this is the building blocks or the foundation of understanding what type of service, the differentiated package of care we need to do. So in planning this differentiated models of care, we need to answer these 4 questions very stringently and just look at the center of it is we are going to give a benefit to the patient living with HIV, and it is not either the center decongestion is not the primary criteria. So that's why we also sometimes call these as patient-centric packages of care. Okay, so this is another term that I'll be introducing to you, and it's already part of our operational guidelines. Now, this picture I have taken from article that was published in Feb 21, which actually shows us the expanding vision of differentiated service delivery models. For example, if you look on the left, the image on the left, that is DSD 1.0, in that surrounding the patient is HIV, and around HIV are all these NCD, TB, other services of care. Now, on my right, you see that there is a differentiated care 2.0, where you actually see that HIV becomes a part of the management or providing care to the PLHIV, and all others also have that equal share of providing care. For example, it's HIV, it's family planning services, it's tuberculosis, it is NCDs, and any other. So this is the vision change that we need to see in providing care or the differentiated service delivery models that we have to take them forward. Now, to answer the question, who should be offered differentiated care? So if you have read the operational guidelines 2021, the chapter 4 is dedicated to this. That is a patient-centric differentiated care packages for retention. So this entire chapter is what we'll talk about everything what I will be basically trying to give some examples and share some of the infographics from different projects that we have. So before we answer the question, who should be offered differentiated care, I just want to walk you through what is retention, what do you want, what do we mean about this. So if you see this infographic, what you see is there are different stages of leakage of cascades from the time the patient is diagnosed HIV positive to the time that the patient is actually put on antiretroviral therapy and routinely followed up. If you see between the stage 1 and stage 2, that is from the time of diagnosis to the enrollment in care, some patients actually miss from registering from ICTC to ART center. There is a first linkage loss that you see. The second loss you see is all those patients who are registered to be initiated on ART is your second loss. And then you also see the third loss occurring when a patient is on treatment. You also lose somebody during the course of antiretroviral therapy. Now, at least within the ambit of the ART center, once the patient is initiated on ART, we have to provide quality services, patient-centric services, so that you retain the patient, and also to ensure that they are virally suppressed and mortality is comparatively decreased among those who are stable. So these three will be our primary endpoints or outcomes in terms of managing patients who are initiated on ART after registration. Now, in order to do that, the current guidelines have simplified the workflow. And we already know that the LFUs or mortality is higher in the first 3 to 6 months of initiation. And then the major causes of LFU include certain things like side effects of ARVs and gaps in preparation, mainly in patients during the first 3 to 6 months of initiation. And it is possible to identify probable LFUs and counsel them adequately. So on my left, you see the picture, you take 2 steps forward and 1 step is backward because you are losing patients either because of mortality, loss to follow-up, or not able to re-engage patients, or they're slipping down the cracks, like not being initiated on ART itself. So if we have to definitely take our step forward, we need to watch our backward step and try to prevent loss to follow-up, number 1. So prevention of loss to follow-up is a major strategy or what we do. it's not bringing back who is lost to follow. Re-engaging is a final resort to basically increase our second 95. But to retain the patients and how to prevent that loss to follow is one important activity. Again, this is a framework for patient-centric differentiated care. And during the first 6 months, rapid ART is what we talk of. And then during the first 6 months, we want to retain them. That's called as early retention. And long-term retention is once you initiate ART after 6 months, then you think about a differentiated care to decrease barriers in these people. So if I ask you a question where actually the differentiated care comes, not just in the after completing 6 months, but even that 6 months package that you're providing is a differentiated specific care to prevent LFU and death among the patients who are recently initiated on ART. So just take 2 minutes of your time to focus on this infographic. So what we are saying here in this particular slide is, if you look at the bottommost, that is, once you detect somebody HIV positive, that is, once you enroll a patient, for the initial 6 months is a very critical time for us to prevent patients from loss to follow-up or death. So the guidelines say that all patients who are initiated on ART until 6 months, they get their viral load, their first viral load, all new patients should be categorized as package A. That is, these patients will be considered as package A patients. And what they should be getting, we'll just look at. So all newly initiated, and among those newly initiated, if somebody is having an advanced HIV disease, that you call them as an A plus package of care. This A plus, so can anybody just type in your chat boxes what is advanced HIV disease? Who is a patient with advanced HIV? Just take 10 minutes, sorry, just take a minute and put down who are the patients who would be considered as having advanced HIV disease. Just put it in your chat boxes. Okay, nobody started still. Who is called a patient with advanced HIV? Very good. Somebody tried CD4 less than 100. Anybody else? Fast. Very good. Stage 3 and 4. Virally unsuppressed, those with stage 3 and 4. CD4 less than 200 and PLA plasma viral load more than 1000. Anything else? Anything else? So you had, I mean, so many definitions coming up. So there is just one single definition for you. What is called as an advanced HIV disease means a patient with a CD4 count less than 200 or having a stage 3 or 4 infections among patients who are aged more than 5 years of age. And all children less than 5 years of age are considered as advanced disease management, are considered under ADM package of care, all less than 5. So most of you have given bits and pieces of answers. So the complete answer is any patient presenting with a CD4 count less than 200 or with WHO clinical staging 3 or 4 and age less than 5 years of age, okay, or age less than 5 years. All these are considered as advanced disease management cases. So they will be labeled as A plus patients. And once a patient completes is viral load at the end of 6 months, based on the viral load, they will be either going to package B or package C. So in package B, if they are virally suppressed, they are stable, and so they are under package B. if they're unsuppressed or unstable, then they go into package C. Now, by doing this, what is the benefit for the healthcare staff at the ART center is, suppose you're getting 100 patients in your ART center, what is that package most of your patients are on? Is it A, B, or C? You can start typing. What is that most of your patients are on? Which type of package most of your patients are on? A, B, or C? Fast. Very good. So it is package B. That means by this, what you have to understand is these people, even if you give some differentiated package, or even if they don't see regularly, these people are now virally suppressed. So they can be offered something else. And package C should be offered something else within the ART center, and A plus also. So this is how this differentiated patient-centric services across the treatment cascade is one very important tool for us to understand what is that service the patient A plus, B, and C should be offered within an ART center. And this will help you plan in such a way that all package B patients can go very fast within the ART, can move. Maybe 1 minute is given to all of them. If somebody is in package C, you may give 5 minutes. Somebody in package A and A plus, you give 10 minutes to that patient. So that is how you can actually organize your footfalls within the ART center and try to provide that specific care what the patient requires, rather than giving a blanket one size fit for all sort of management. Right. So these are given in your guidelines very detailed. For example, if somebody is in package A, what do? You give preparedness counseling, rapid ART, TB preventive therapy. If somebody is in package C, that means his viral load is not suppressed. So you're going to give him EAC, you're going to give him, if they are coming from a KP population groups, then you want to do some CARG. So this is how. And package B, if you see, most of the differentiated decentralized ART refill is again one sort of differentiated care that we offer. That's why most of them, if you have to refer somebody to an LAC, if you want to refer to an OST, if you want to refer to a CSC or a community ART refill groups, the most of your patients who will be eligible are from package B, but not from package A or package C. So this is the importance of understanding which patient belongs to which package of care. You have to classify every patient in your ART center like this. Then it's going to be really, really easy to manage your patients. And you know who will require care, who will not require that much of care, who should be given the utmost importance at the ART center during the routine clinical hours. Now, package A, for example, you know that they should be offered preparedness counseling, identification of caregiver, ART profile. So this is the package of care for those who are starting newly on ART. For 6 months they will be on intensive follow-up, and every month or fortnight there will be a call going by the counselor or the care coordinator to the patient. And package A plus will include all the advanced disease management package. Now, on the white card, if you see the guideline, what they say is you put up a yellow sticker and put on that particular white card A or A plus, depending on it. All new patients should be marked like this on the white card. Now, if you had a patient who got his viral load test now after 6 months, so the next two packages will happen only if you have a viral load. Suppose if a patient is currently on ART since many years, then they will not go into package A or package B. You will have to assess the viral load and push them either in package B or package C. So package A plus are only for new patients without a viral load. All with viral load should be considered in packages B and C. Please remember that. Now, who is a stable patient? This is again, I've just pulled up from the guideline. There's nothing, no rocket science in this. So, who is on ART at least for 6 months, no adverse effect, no opportunistic infection, virally suppressed, or if you don't have a viral load, you should have an adherence for last 3 months, and then you have a CD4 count which is raising more than 200 basically. So this is pretty much, so all these stable patients only will be mostly eligible for any differentiated sort of care, but they will be given patient-centric care depending upon whether they are stable or unstable. So package B, give a green color to that patients, all who are there. And what all do we give within the ART center? Multi-month dispensation. This we were giving. Currently, there's a transient stop in that, but one of the model what we are giving within our ART centers is a multi-month dispensation, wherein we are calling the patient within 48 hours. If there is a miss, we share the list with CSC and LFU tracking. And we also have something as community ART refill groups or a CARG. This example is again taken from Andhra Pradesh state, wherein they were able to actually link up with CSOs, CBOs, TANGOs, and give those patients of care at that particular center itself. I'll not go deep into this. And package C is for patients who actually are unsuppressed or who are not stable. They should be given step-up counseling, case management, or individual care should be provided, because you do not want these patients to slip out of the care. So now I'll ask 5 questions. So everybody keep answering. So the first question is, if a patient who is on ART, I have just started ART 1 week back, and his CD4 count is more than 200, to which package this patient will belong to? Newly initiated with a CD4 count of greater than 200 in stage 2. So where do you classify this patient as? A, B, C, or A plus? So just put it in the chat box, whatever is that, faster. I'm just seeing 8 or 9 of them. Last 10 seconds. I'm noting who are really active on the chat. Thank you for answering. Yeah. So I'm seeing many answers. That means I didn't convey properly. So just listen, okay? What I told is a patient whose CD4 count is greater than 200 and stage 2. When I say that, that means the patient is not having advanced HIV disease. So he should not be in A plus. I told the patient is just started 1 week back. That means he's a relatively new patient, less than 6 months. So he should be in package A. So most of you have, majority of you have put package A. Good. Now the second case, okay? The first case is gone. Second case, a patient who was on ART for more than 2 years comes with a viral load of 1 lakh copies. Where do you classify this patient? A, B, C, or A plus? Very good. Good, good. Yes. So it's C. Next case, okay? I have a patient who was on ART for 3 years. He was lost to follow up in the last visit. He was LFU, and now he is coming back. And his viral load is not yet done because he is an LFU. He came back. So where should I put this patient? In which group should I put this patient? Very good. So this patient will go to C. All re-engaged patients will go to C. Last question. A patient with TB, viral load less than 1000, on ART for more than 2 years. Where do you classify him? Oh, it's not A plus. It's not B. B is only suppressed. B is only suppressed. A plus is only if you have an advanced disease and you are new. Dharmapuri and Kakinada, just whoever is doing there, just to correct you. This patient is on ART for more than 2 years. If it is less than 6 months, then you go for A or A plus. Other than that, if somebody is unstable, you put him under package C. Understood? Good. So I think now mostly you understood and what is yeah, thanks Ma. And mostly now you understand why is it important to classify your patients so that you visibly know who is stable, who is not stable, who requires your time and who is not regular on treatment. Hope I think by now the concept is clear to most of you. Let's move on. Thank you for your active chats. Right. Now, this again, most of you all are familiar with this. All patients who are in a package C, okay, should at least get a minimum of 3 consecutively for EAC. And we also have to ensure that one important thing that we usually forget is in most of the unsuppressed cases, we also have to ensure if there is a spouse or a partner or children during that, they should be actually referred for an index testing at the point of time. And if they're not able to come to ART center, we try to give them 3MD, telephonic counseling, you document all this. So very important thing is if a person is getting unstable, that doesn't mean that you cannot offer 2MD or 3 months dispensation. If if the patient is unstable just because he cannot travel or can't afford the travel expense, then possibly he is a good candidate where you should be offering either a 2 months or a 3 months dispensation under the personalized care that I already spoke in my previous slide. When I say individualized care, this is what it means. That means monthly phone check-in by the counselors, SMS reminders, home visit by peer counselors. Okay. And if there are any like, is there a gender-based violence, intimate partner violence, whether the patient is depressed, okay. PLHI who return to care after being missed or LFU should be provided a friendly and welcoming environment, which is very important. And based on some centers data review, the patients who are coming back, that is who are after retrieval from any of the LFU drives, if you're getting back, these are the very important patients because they are going to lose treatment in the next quarter. If you see what happened to, if you see all who are lost to follow-up, actually, your 30% of the patients will be from the patients who are re-engaged or retrieved. You can see your own data. Minimum 30%, maximum you can have 60% too, and they will contribute to 20 to 15 to 20% of the deaths that you see next. So this becomes a very important group under group C. If you have anybody re-engaged into treatment or retrieved into treatment, they become very important group, and you need to next prevent LFU or death in that patient populations. Right. PLHA with poor ART adherence, we need to look into whether they are more flexible to support them with any other DSD activities. Now, all the differentiated service delivery models broadly can be divided into two. That is, they are called as a group models or an individual model. When I say group model, it is like, again, it's I'm giving you examples. Welcome back clinics in children. This is one sort of activity that I have personally seen in Andhra Pradesh and I've seen in Manipur specifically, where they have retrieval clinics for children. They bring the children, they have specific days for that. They do some camps where the children are actually reassessed thoroughly based on their weight measures, and also they also try to link up with certain NGOs and try to give some nutrition. So this is all happens in that welcome back clinics for children, which is done every quarter, and they check for their viral loads who are eligible and CD4 counts if required. And there's also some adolescent adherence clubs. This again in Mumbai is one best example. I'll be sharing those slides after this. But and then managed by clients. When they are managed by clients, these are called as community ART refill groups. Okay, and if they are done like within a group model, it's like a family centric care step up counts. So the step up counseling that we offer to patients who are not suppressed on ART is actually a CARG model, because you're separately having them and you're managing your clients within the group models that you have. And community or client led ART deliveries are usually with the at the TI sites. And individual models, that is like our one-stop centers for transgender population, for female sex worker population, or our link ART centers is again a best example of facility-based individual models. And certain orphanages where the children are provided ART at the decentralized and not based at the facilities. That means, for example, there is a church, there is a healthcare provider or a community member they offer to that smaller community, or at a railway station, or a mobile outreach ART delivery. We have one good example from Nagaland, that is on a bike intervention, and then home delivery, which we are already doing it. So this is how we classify it, and this I have taken it from the WHO 2021 guidance. There are different ways of actually segregating them and trying to do. But one very important thing what we need to remember at the end of the day is whether the patient is getting ART at a facility, or somebody is going and giving, or somebody on behalf of the patient is coming and picking up, or the patient is coming to the ART center, but we are treating them in a holistic manner where there is no stigma attached, or there is no any other need that we are leaving the patient away from. So to close gaps in terms of all access and also management, these are the DSDM categories that we see. So busy slide, but this is one intervention of from Mumbai. This is specifically catering to children aged between 15 to 19 years. And this is a Mitwa initiative where children are, sorry, the adolescents were looked up, were trained, and the key aim of this is to identify community is to identify good adolescent speakers there, where they represent their peer group. Okay, and they also get trained on certain life skill management. Counselors are also trained on this. So this is one very good initiative that was taken up there, engaging all the adolescents, and we tried to have some peer leaders developed from them. And the second is a continuation of them. So the thematic areas, what was expected from them, adolescent friendly health services at the ART centers. So this is one intervention where ART centers can look, what can I do for my center? This again, I have taken the from Andhra Pradesh, where the problem was actually we had many patients who were traveling for more than 50 kilometers. So the government do not want the patients to travel so much, and they were thinking that LFU was because of this. And we tried to ask patients whether they were willing to go, and to our surprise, we felt that around 50% of the patients were willing to go to decentralized sites. So this again is that unless we ask the patient whether they are interested to go actively engage, we will think that because of stigma they may not be moving. But this proved to be wrong in our case, and almost 50%, that is 10,000 of the patients, we are now over decentralizing or pushing these patients to the to the link ART centers or any other center which is close to their residence. This is another intervention again from East Godavari district in Andhra, So here, this is, we identified one CBO organization called Nari Saksham, wherein we had most of the key populations, that is FSWs, were actually taking ART from there. We want to ensure that ART is provided at their own community setting. So this we've done it as a link ART center. If you see the graph, this has increased their suppression rates to almost 99%, 98%. Okay, retention is 93%. So giving ART within the community setting in a stigma-free environment will actually enhance retention rates. This is what I was saying, the welcome back clinics, a differentiated care where children are seen separately. And along with that, we tap the resources of having some nutrition support for these groups. This was done along with many other NGOs who are supporting this in Andhra Pradesh. And we have again seen that there is an increase in the viral load coverage from 67, 65 to 86%. So this is one way of looking at how we could actually have a separate clinics for children and how to support them to ensure that they have their heights, weights, and all other clinical parameters reassessed without fail. Because this is one group where you can't expect every child to come for a clinic every clinic visit, but the caregivers bring them. But we wanted to see that they do not get a subtherapeutic dosing just because we do not measure their height, weight, and other parameters. This is again closing gaps among key population groups. I think again this is an example from Andhra Pradesh where we have seen that most of the key populations who are on ART, we are able to have a suppression rates of more than 93% in them. And the state also started to dispense ART directly from the community settings of where the TA NGOs are located. This is in prison settings again. So currently around 92 inmates are provided. We have a viral load coverage of almost 93% and also viral suppression rates. Currently they exceed even 95%. So we know that all patients in prisons are majorly getting their antiretroviral therapy regularly and they're all suppressed. So this is what we want to know at the end of the day. Unless we tease out each population group and how the drug should be given, how to monitor them, we cannot know them. So we need to have cascades for different populations like this. And this example again I take from Mumbai, wherein they have done almost around 50,000 patients. Sorry, around there was so many patients, around 5 to 6,000 patients who were lost to follow up, and also there was a massive drive using some group SMSs to the patients, and then wherever the message had reached, patients have started to come back. So this is one way. How do you use a technology for that? This again is mainly among patients who are re-engaging or not, or who are interrupting treatment very frequently. You see on the right, we have miss one, miss two, miss three. So what happens is whenever a patient does not come on that day, his card goes into that miss one, so that you can visually see that, oh, today so many patients didn't come, I need to actually make a phone call to all of them. So as you expect that your miss one box, you get very few patients in that. Miss two, you shouldn't be getting. Miss three, you should not get. So this is how visually you create an impact, that you need to actually make calls or ensure that so many needs to come back. If it is in your lists and all, you cannot see visually how much is that load. But if the cards are in front of you, definitely you know that there is so much of retrieval that needs to be done, or calling activity that needs to happen. So this is how they segregate the cards and put it based on miss one, miss two. Yes, this again, I was talking of the one-stop centers. To my left of it is a transgender health and wellness clinic that was established in Manipur to the support of Manipur State AIDS Control Society and the CBOs there. So here again, there's we have started to dispense ART there. We have started. I mean, there is a clinic wherein they test for syphilis, they test for HIV. There's a counseling, mental health. So this is again a focused intervention where we want to ensure that the transgender population access services without stigma, discrimination, and the place where they could actually come forth and seek services. To my right, you can see in the upper half is a concept of an evening clinic. That means where, because the key populations may not be able to come to our services at 9 to 4 sort of timing. So to make some flexi timings, this is one other opportunity or one other way of giving antiretroviral therapy or STA services to the key populations. The lower panel is that you see that bike. It is health on bike is the intervention that currently is in Nagaland. So this particular bike takes care of a comprehensive prevention packages of services. Along with, on the way, they also have some stops wherein they also give antiretroviral therapy to the patients who are in the far-flung area. So this particular biker goes with the HIV testing, condoms in it. They also do a sort of dispensation. They have an IEC material as. So this is a multi-purpose sort of thing. And you see the roads. This is the only way how we could commute to those places. So this is another way of a differentiated package of care, how the services are moving out. And these are different other clinics that we have in other parts of the country. Like in Telangana, you have a TG clinic again. You have a e-platform. You also have a community-led models. So these are several other models, differentiated care models that are already there within many states. I was also saying in my initial slide that differentiated packages of care just are not limited to treatment or prevention, but it can go broad to laboratory services too. So here is an example. We are showing that there is a hub and spoke model wherein the samples or specimens are collected from the key population groups or the TA NGOs, and then the samples are shipped to the ART center. From there, they go to the lab. So this is a hub and spoke model wherein it is conducted in camps and prisons we are doing. And there's also peer outreach where we collaborate and bring in patients for specimen collection. So this is an showing where we have those sites and how it is being done. And this is a way where we are trying to put all the models together. This is a slide from Andhra Pradesh. So different models are being done there, differentiated service packages of care. I deeply acknowledge the National AIDS Control Organization, the CST Division, the Mumbai District AIDS Control Society, the Manipur State AIDS Control Society, Nagaland State AIDS Control Society, Mizoram, Andhra Pradesh State AIDS Control Society, and PEPFAR India for their contributions to this. And I have taken slides from different presentations that had taken place at different fora. Thank you.
Thank you so much, sir, for the detailed session. Any questions from the participants? Please feel free to type in the chat box, or you can also unmute your mic. Are there any questions from the participants? So I don't think there are any questions.
Sure. Yeah. Thank you.
Thank you so much, sir. Thank you to all the participants for active participation and patient listening. We'll conclude the session.